Two unbelievable comeback stories, Damar Hamlin and Christian Eriksen. It's amazing to see these two athletes come back from such a horrific cardiac event. But if you missed it, let's rewind the tape. I remember watching this game live. I couldn't believe my eyes.
Brought the stretcher out. They have that backboard out.
The whole world stood still.
Is the one who was in on that stop on T. Higgins.
Watching this game was even more difficult as my kids were with me watching this game live. They were asking me, "Daddy, what's going on?" I was shook.
Suddenly.
But did you know that this is common? There are over 356,000 out-of-hospital cardiac events that take place like this every year. And of them, 70% to 90% are fatal. You only have one heart, but has anyone taken the time to explain what it is and how it works? What if you could talk to a cardiologist like Dr. Rick Ammar from Heart Place? This is part one of a three-part series where we talk about cardiology, how it works, Q&A with Doc, and also different diagnoses that affect the heart. Let's go. Hey, Charlin family, this is Charles. We have a special guest today, Dr. Rick Ammar with Heart Place. Thank you so much for hopping in and chatting. We're going to have some fun. We were actually just talking about this in general, about how there's not a lot of good education for families.
For sure.
Regarding cardiology, regarding just healthcare in general. So appreciate your time. Appreciate your time.
My pleasure.
So if you don't mind, just tell us about yourself in general. What got you to becoming a doctor, specifically cardiologist?
Sure. Well, that's a bit of a long story. So I when I was growing up, I was a math and science kind of guy. I recognized that I couldn't write papers very well. So I needed to be a math and science guy.
Nice.
I went off to be a biomedical engineer in undergrad. And the idea was I could either become an engineer or go into medicine. But I figured an applied science was kind of going to be my thing. In those days, which was a really long time ago, engineer, there weren't personal computers in those days, so engineers were relegated to a drafting board, and it kind of, I'm a little bit more extroverted than that. So I decided medicine, I would give that a swipe. So I ended up going to med school, but with the whole math and science background, how things worked was really interesting. So, cardiology was especially interesting because you have electricity, you've got pumps, you've got flow, you've got, there's a fair amount of sort of physics and, pardon me, and that type of thing. So that was especially interesting to me. And so I initially planned to go be a research guy.
Oh, wow.
So I went off to a research-intensive training program, which was the University of Iowa. It was very, very good at that. And I was doing physiology-based research and really thoroughly enjoyed it. Kind of about that time, the molecular biology sort of genetic revolution was happening. So a guy who was getting started in his career in research would have needed to sort of get into that aspect of research, and that was not interesting to me. So my fallback plan was to be a doctor. So there you go. That's how it was a long story, but that's how it came about.
Cool. What are some things you mentioned that, with your love for math and then going into becoming a cardiologist, what were some things that really got you to really make that decision?
I don't know if there was any sort of discrete thing. I actually loved almost everything in medicine. I went to med school with the absolute intent of being an orthopedic surgeon.
Really?
Yeah. Well, I was a sports guy, growing up and whatnot. And I thought, sure, that was what I was going to do. The one thing I did not like.
Who's your favorite sports team?
At the time, Pittsburgh Steelers.
Okay.
Okay. So I was sure that's what I was going to do. The one thing I didn't like in med school was orthopedic surgery. I loved everything else. The whole quest for a diagnosis, and trying to solve a problem.
Gotcha.
You know, as an engineer, I wanted to solve a problem.
Yeah.
And that, I think that was what drew me to, you know, the more sort of cognitive-based specialties. But I also like fixing things, you know, so cardiology has a little bit of both.
That's cool.
Yeah.
Wow. That's pretty neat. How long was that process once you decided to become a cardiologist? How long was that process? Just for someone if you're considering being a cardiologist.
So after high school, there's 4 years of college, 4 years of med school. I did a 4-year residency in internal medicine, which typically it's 3 years for for internal medicine. But I did a hybrid research clinical thing. Okay. So 4 years for that, 1 year as a chief resident, 3 years as a cardiologist, a year and a half as an interventional cardiologist, and then supplemental training later for a couple of years to do vascular medicine.
Wow.
So it was 19 and a half years after high school.
That's amazing. Wow.
Yeah, and you'd think for a guy with all that education I'd have turned out a little smarter.
No. So you must have graduated when you were like 12 or something?
No. Yeah, I'm older than I look.
Wow, that's pretty cool. So is that like from your experience just in general, is that the normal kind of like
I think
route?
I was a little longer at it than most, like, slow on the uptake. You know?
No, right. That's pretty cool. Wow. What if someone is just, you know, wanting to feel like they have an understanding of what a cardiologist does? I know there's several different types of cardiologists.
Yes, for sure.
But what, you know, kind of run us through like the basics of what a cardiologist does and maybe the 2 types or 3 types.
Well, there's more than that. So cardiology actually was a subspecialty of internal medicine, still is actually. It's very soon going to become its own separate discipline. So it's breaking off from internal medicine, and it really ought to. So there are the simple way to say it, there are electricians, there's plumbers, there's pump guys, and there's kind of imaging people.
Okay.
So the electricians are called electrophysiologists, and they deal primarily with heart rhythm disorders. You may have heard of ablations for atrial fibrillation. They tend to be the people putting in pacemakers. They install defibrillators to protect people from heart rhythm disturbances. And that is a whole separate training pathway after cardiology. The plumbers, and I'm a plumber. Cool. So we're the angioplasty guys. Okay. So balloons and stents. Okay. You know, making the blood pressure the same everywhere. You know, so I say that's actually what I do for a living is I make the blood pressure the same everywhere. And it took 19 and a half years to figure that out. So like I say, slow on the uptake. And then there's imaging people who will focus really on primarily advanced imaging these days. So imaging the heart with CAT scanners or MRIs or PET scanners. Some of that does really require more specialized. And all of these specialties can kind of cross over. Okay. So I put in pacemakers, for example. Oh, yeah. I'll read PET scans, but I don't put in defibrillators. I don't do ablations.
Gotcha.
So and almost no two cardiologists look alike. You know, there's so many different things a person can do. Increasingly, there's more of a discipline of vascular medicine. And I would tell you that really is what I do. Okay. Yeah, so I'm a vascular guy as much as I am anything else. So fixing blockages in the legs, salvaging limbs that are have ulcers or pain. I repair abdominal aortic aneurysms, stent carotid arteries. So and then there are people who kind of more or less practice general cardiology. Okay. And there's heart failure guys too, I should say that as well. So heart failure has actually kind of become its own discipline as well. So and those guys really pretty much just do heart failure.
Wow, only they kind of specialize.
Yes, for sure.
Wow.
And that's quite specialized. We actually have several people in our group who are as good at it as anybody there are.
Wow, wow. So when when someone's going to see their internal medicine doctor,
Yes.
and then they're getting a referral for a cardiologist.
Sure.
What's, someone is like, maybe they say they have a heart murmur or something's going on, right? And what are some of the things that you see patients come to you for, like just generally?
Oh boy. Yeah. Yeah. So very generally, I think when a person or when a patient or a family member or the patient's doctor thinks of a person possibly having a heart problem, they're worried.
Yes.
Right? Sort of anybody can order an EKG and, that kind of thing. But to have somebody say, is this person in trouble or not? Asking somebody who does it for a living is a good idea. So I see my job as being the person who analyzes and mitigates risk from a heart and vascular related thing. The problems are all over the map, from high blood pressure, high cholesterol, heart rhythm abnormalities, funny heartbeats, shortness of breath, chest pain, leg pain, previous stroke. I mean, it really is quite a broad swath of, of complaints. And sometimes and actually this is particularly thoughtful of either the doctor or the patient. They just feel like they just can't do what they could do a year ago. That could be a heart problem. Yeah, you're right. It could be. So that's the person that never ends up in the hospital. Because they were smart enough to
make the decision,
get themselves checked out.
Wow. Do you see like that? It's a common thread that a lot of people kind of wait till like either the last minute or.
Oh, for sure.
As we're all human, right?
Yes. Yeah. So the time to meet your cardiologist is not after you've been resuscitated. That's a bad time to meet your cardiologist.
That's true.
So it's a far better thing to meet them in the office and have, a risk assessment and a treatment plan generated, because the treatment plan for a cardiac arrest is pretty straightforward.
Yeah.
CPR, defibrillators, ventilators, if you're lucky.
Wow. This is kind of, you were talking about you're a sports fan. I was just thinking about this. You see a lot of athletes are having cardiac arrest.
For sure.
What are some things that you're just from with your experience, what are some things you've noticed, just in general? Last year there was some big things, especially with the Buffalo Bills, and
for sure.
What are some things?
Well, there's definitely things that put, all of us at risk for those kind of things, and athletes in particular, but many of them have, heart muscle diseases that are often not detected, and these guys, are highly trained athletes, so they're able to kind of push through symptoms that,
Gotcha. That normal people would pick up. They're like, oh,
that's
something's
right.
wrong.
That's right.
Wow.
But, for example, something called hypertrophic cardiomyopathy, where the heart muscle is super, super thick, that puts a person at risk for sudden death.
Wow. How do you know that you have that?
Like professional teams these days, every person, particularly for professional teams who are investing a few $1,000,000 on somebody, they're getting screened. So
Gotcha.
that's how that's getting mitigated.
But for normal everyday
for sure, a high school, is probably not going to screen, do an echo on every one of their patients, or every one of their players rather.
Wow, yeah, because I was watching the Euros recently, and I think 4 years ago there was a player in Denmark who literally just collapsed on the field.
For sure.
And everyone, the whole world was watching, right? So it was like, oh my goodness, like that.
Right.
And like that is not something that people want to see, but at the same time, it's like a wake-up call.
Well, it is. The heart disease still kills more people more Americans than anything else. And 55% of people who have heart problems find out about it for the very first time because they fall over dead.
Wow.
So, that's a bad first symptom.
Yeah.
It's much better to pay attention to yourself, find yourself to somebody who can assess and mitigate your risk. That's that's the way to go.
That's good.
Right.
As someone's watching this or listening to this, like, what are some, some basic things that people need to do in general to make sure they're taking care of their heart? I know you probably get this a lot, but
Yeah, for sure.
What are some basic things to think?
It's not a bad idea to just go to your doctor, have your blood pressure measured. If you're over 50, probably got to get an EKG sometime.
Okay.
Get your cholesterol measured, make sure you're not diabetic. And have just an assessment of kind of your fitness generally. And if any of those things seem off, there's additional look,
Gotcha.
maybe walking on a treadmill,
Gotcha.
in a cardiologist's office isn't a bad idea, or having an ultrasound done of your heart or something. There's some pretty simple things that can really put you in the low risk bucket or the high risk bucket or somewhere in between. And that's honestly what we do for a living.
Gotcha.
That's our shtick. Of course, there are times when we're rescuing people from the brink.
Yeah.
But the vast majority of what we do is not that. The vast majority of it is helping assess and mitigate risk in somebody who's walks in the door of the clinic. Yeah.
Gotcha. When someone, you mentioned EKG. Someone doesn't even know what that is. What is an EKG? What does it do?
Yeah, so an EKG is a very simple test. It takes a couple of minutes. What happens is a few little patches and wires are connected to your anterior chest wall and fed into, these days, a computer that makes electrical recordings from the surface of your chest. And if you're super still, that's going to come from the heart muscle being activated. And that will inscribe an electrical signature on a piece of paper. And it's not the end-all be-all, of course, of cardiovascular diagnosis, but it's a nice starting place. Pretty good screen for some things. Now, obviously, depending on the person's circumstances, there are many other things that can be done, but that's a pretty good place to start.
Okay. And then when you get to like a stress test, what is the difference between that for someone who's, that maybe the doctor says, okay, we need to do a stress test. What does that look like, or what does that entail?
So often a person is hooked up to that. Well, they always are hooked up to an EKG, just like they were before. But then that person is asked to walk on a treadmill most of the time. So you're walking on a treadmill, it gets a little bit steeper, a little bit faster, and it stresses the heart. So as the heart is demanded of the body, its muscles and whatnot, the heart rate has to increase, the blood pressure has to increase. And if the heart is unable to provide that additional blood flow, it's going to be apparent. And if the heart is trying to do that and it is unable to do so because it doesn't have good blood supply, then it will inscribe an abnormality on the EKG.
And that's how okay.
So that's the most basic stress test. Very often these days, an image modality is added, like ultrasound, right before and right after. And what you're looking, if the heart squeezes like this at rest, you want it to pick up a lot with exercise, and if only part of it does, that's a problem.
Wow.
There's also nuclear imaging. So you give actually a radioactive medicine, a tiny little dose, that will travel to the various parts of the heart in proportion to its blood flow. So you give that at rest, and then after stress, you should be able to see that the flow should increase all over the heart. But if there's a spot in the heart where the blood flow can't increase because there's a blocked artery, then that part will not show up with increased flow.
Wow.
So that radioactivity we can detect with a giant Geiger counter, basically.
That's cool.
You can also do those tests with a chemical agent rather than a treadmill for those who are not able to walk. So.
And you can monitor that throughout the whole process.
Absolutely.
Wow. So you're just talking about the flow of the heart. For someone who doesn't know the flow of the heart, you mind taking us through how the blood flows through the heart?
Well, sure. So the heart is just a giant pump. Well, not a giant. It's about the size of your fist. But it is a pump in that all it does is squeeze. So there's a circular muscle that squeezes, and just like if you took a water balloon and just squished it, the blood's got to go someplace. Well, there's little valves in the heart that provide directionality to flow. So the veins carry unoxygenated blood back to the heart, so the heart can pump that blood out to the lungs, and the lungs then basically put oxygen into the blood. The heart then collects that blood from the lungs and then pumps it out to the great big blood vessel that feeds blood everywhere called the aorta, and it distributes the blood to all the tissues of the body. The tissues will use up the oxygen out of it, and that blood then goes into the veins and the cycle starts over.
Yeah. So you mentioned like a big muscle or a pump.
That's right.
What are some things that, patients or people can do to kind of increase the muscle strength of that?
Yeah, well, there's a limit to that. You just want it to be normal.
Okay.
Yeah, so if it's too low, that's a problem, and that will often cause heart failure. And if it's too strong, that's actually a problem and will also often cause heart failure.
So you want
it to be right.
Cool.
Yeah. So you don't want to try to
cool as a pickle, like right in between.
Yeah, that's right. So you don't really, the goal of sort of taking care of your heart is not to make your heart even stronger or super strong. That's actually counterproductive. You just want the goal of sort of taking care of your cardiovascular health, proper eating, make sure your cholesterol, your blood pressure, diabetes is taken care of, and you don't want blockage problems, and not excessive alcohol, no smoking, particularly cigarettes. Those are bad things. So, and then get yourself checked out.
That's good. Wow. And you've been doing this for a long time. You mentioned, yeah,
Long time.
And you've seen a lot in terms of just families and patients that need care, right? What are some things that you've seen from a hospital standpoint, ER standpoint, that you've seen that the most reasons why people go to the ER, and what are some reasons that you've seen that can actually help limit that?
Sure. So the first thing I would tell you about that is, boy, is that different in different parts of the country. So I practiced for a long time in Iowa, for example. So this is a very rural community, older farmers. They're maybe very stoic, sometimes a little obstinate, let's say. So getting them
stubborn.
trying to get them to go to the hospital in the first place is difficult.
Yeah.
And people would in that part of the world tend not to go to the ER at the drop of a hat. There tends to, I think, at least at the time I was practicing there was a lot more availability of primary care doctors. So people felt like they could call their doctor and, get an answer. In North Texas, I think there is a relative, I think there are not as many primary care doctors available to people as is needed, to be honest with you.
Yeah.
And I don't know why that is, but I think that North Texas tends to have more specialists than primary care doctors, and I don't think that's necessarily a good thing. Of course, there's been the passage of time as well, and now we have Dr. Google available. So,
good old WebMD.
Yes. So, before I think a person would, maybe have some sort of symptom and either kind of blow it off or wait to call their doctor, and now you get this answer.
Fear.
Yeah, and fear drives people. Generally are not that interested in going to sit for 4.5 hours in an emergency room to find out an answer to their question.
Yeah.
So they're seeking an answer, and incentives drive the way many things are manifest. So if you're going to make a post on Google for a Google search, of course you don't want to mislead somebody from not going to the emergency room.
Right.
So the fear factor is pretty amped up, and so I think people go to the ER much more readily here than perhaps. they would in
Different areas.
different parts of the country.
Wow, yeah.
Yeah, that's right.
And that you mentioned that, that's a great point, because I know that just in general, like you look at our healthcare system and Medicare and decreasing the cost burden of hospital stays, ER stays, a lot of hospitals in general are trying to decrease readmissions, right?
For sure.
For sure. And so, but I think at the same time, what are some things that as a whole, as healthcare as a whole, practitioners, doctors, providers, what can we do to kind of help patients limit that?
Yeah, I would say there are the incentive structure, meaning how people are paid, drives, like any industry,
True.
it drives
100%.
behavior. So I think there are probably some hospitals, at least at the moment, who are pretty happy to have readmissions. That doesn't really bother them that much, right? I think that's changing, because I do believe that payers are going to start creating episodes of care and paying for the episode, and if that involves another admission, that one's on you. Then I think that will change behavior quite a lot, and that has been called value-based care. So that's a new buzzword in medicine. How that becomes manifest, I really honestly, I don't think any of us know. But the hospital is for sure the most expensive place to receive healthcare.
Yeah, true.
For sure.
Yeah.
Just in round numbers, to land in the hospital, it's several $1,000s just for the bed. And that's before you get any medicines or any tests, or you're hooked up to a EKG telemetry thing. Then you have to pay your doctors and your tests and your medicines and all these things. So it's a very expensive place to receive care. And even for the most routine thing, like I thought my blood pressure was too high.
Right.
And you decide you're going to the emergency room for that. Well, the emergency room stop is going to be a few $1,000s. The cost of paying the emergency room doctor is a few $1,000s. And you land in the hospital, $10,000, $20,000 a night. Man. Pretty soon you're racking up a pretty good bill.
That's graduation. That's school. That's college.
For sure. I mean, you could pay for a couple of years of college for a couple of nights in the hospital. Wow. And in reality, for blood pressure, blood pressure is the quintessential outpatient condition. Yes. Right? You rarely need to go to the hospital for that. So it's a really good idea to speak to your doctor if you happen to have high blood pressure, or if you don't know what your blood pressure should be. Ask. These days, you can pick up a blood pressure monitor at
CVS.
At your pharmacy at a modest cost. But the most important thing is, don't just get the device. Learn how to use it.
Yeah.
And make sure you understand what the numbers mean, and have a place that you can ask questions that doesn't involve the internet. So, if you can get yourself hooked up with, a doctor's office, or if you happen, a home health agency or whatever, so that you can, rushing off to the ER is a very expensive and often very wasteful way to manage simple things. Yeah. Now, of course, if you're having use something else. I mean, if you're feeling badly, that's a different kettle of fish.
Right.
But if you're not feeling badly and you're looking at a number, might ought to think about it.
Yeah. And that's a really good point, because a lot of times, just like you have a car, you take a look at the car and you make sure where are we at in terms of the levels of oil and, tires and basics, right? This is our heart. And so if we're able to do that in a healthy way, right, and talk to a cardiologist, talk to specialists, and monitor that.
For sure.
I think that'll decrease patients going to the hospital.
For sure. I think the appropriate site of care is going to be a big focus for the healthcare system coming up.
How so? What do you mean by that?
Well, I think in bygone years, a person, their very first contact with the healthcare system would often be the emergency room. And you would go to the hospital, and that's where you would meet your doctor for the first time. Well, your clinic doctor now, your primary care doctor, doesn't go to the hospital anymore. You're not going to meet them there.
They don't,
So You're going to often meet a hospitalist, often very good people, but they're not going to see you ever again unless you end up in the hospital again, which we didn't want to do in the first place. So the most appropriate place and venue for healthcare for a person is the one that is safe, is going to be able to provide as much as they need without overdoing it, and is going to be economical and convenient and all these things. So I think you're starting to see, sort of these urgent care clinics, which are helpful. I think, your company is one that is based on keeping people at home and providing care at home in a safe and comprehensive and sort of holistic manner, and giving patients access to professionals that can answer questions or direct them to somebody who can, or ramp up the level of care that they need in their own home very often. So that's beautiful. I mean, who doesn't want to stay at home and get their care at home? And I honestly see that as being a very important piece for the future. We all know that healthcare will absolutely bankrupt our country, and we're doing a good job of it. We're racing off to bankruptcy. So the only thing we're going to be able to afford are bombs and medicine pretty soon. Nothing else. Well, that's we can do better than that. And again, I think incentive structures, and when I say that, I mean how people are paid. I think that is going to change things. Unfortunately, particularly government agencies don't have the greatest track record in manipulating behavior based on, money. So to some extent, I think organic growth of these type of services, like you're doing, we're working on some of those innovations in our practice as well. So, for example, providing extended hour clinics.
I remember.
So
kind of dive into that a little bit, if you know.
So if our office is typically open from 8 to 5, but if we're open 8 to 8, you have a little bit more opportunity to get a hold of us. We're going to offer weekend hours. Maybe we'll even in some stage have office hours 24 hours. I think it'll be an evolution to get to that, but if we can offer extended hours, then that's a little bit more time available for people to access our services without needing to call 911 because they're worried about their blood pressure.
Yeah, that's good.
I think activities just like we're doing right now, and to help people understand better, when is it time to go to the hospital, when can I wait till the morning to call, and you can have these conversations, of course, with your doctor and their staff and their home health provider or whatever. The more a person knows about their particular problem and where the landmines are, and when are you kind of in a safe zone, the more you know about that, the better. And I mentioned Dr. Google, but I actually don't really mind people looking up things on the internet. I really don't, because if it prompts you to ask questions, then great. If it prompts you to stop thinking or not asking questions, but you just end up calling 911, then it's actually counterproductive.
That's really good. Yeah, and I like what you said about that, because if you have that relationship with your doctor, you have that relationship, and you see a blood pressure reading that's off, right? Okay, maybe knowing what the doctor will say and having those guidelines, and these are the parameters, and reviewing it and saying, okay, what happened in the last 24 hours? What will happen with your medications? And kind of like walking through that instead of jumping to go to the hospital.
For sure. Well, your blood pressure is supposed to vary, right? Exactly. And in all honesty, a blood pressure of 180 over 90, as an example of one of the problems, that is going to hurt you if it stays that way for 10 years. It is not going to hurt you in 10 minutes.
That's good.
So it's not going to hurt you in 10 hours or 10 days or 10 months. So you have time. don't ignore it, of course. The next chance you get to call and obviously monitor it and these kind of things.
Yeah.
But you don't need to call 911 and end up in the emergency room for a blood pressure of 160 over 90.
Then get admitted, then get other issues.
All the other stuff, and often your medicine's changed and no communication with your primary care doctor, and then you got to get new prescriptions. I mean, honestly, the best place to do this is with somebody that knows you, that has a relationship with you, who knows your family, all these things, and maybe knows what medicines you take for other problems, and knows what medicines you've tolerated or not tolerated or whatever, and has the infrastructure in place to follow you up. You can try almost anything. There's 500 blood pressure medicines out there, right? So, everybody's going to need a different combination, and, we'll try something, and, maybe it doesn't work, maybe it works out, maybe there's but we're going to know how to monitor. You can try almost anything as long as you follow it up and monitor it, So,
and that's a good point, because I feel like that's what medicine was initially created to be, right? Is to have that relationship with the doctor, with the patient,
for sure.
and to know what to expect, and
sure.
and have that peace of mind,
For sure.
And so we were talking about a couple weeks ago. You were mentioning about a study that you were a part of. Are you able to kind of expand on that a little bit, or
I'm not sure which one you're
about the amount of admissions that were done recently in the area compared to different tri-states?
Sure. So so our group was part of this. It actually wasn't so much a study as it was actually a payment capitation. It's actually still going on from the federal government. They call it bundle payments. So the notion is the federal government sort of looks at a 5-state area and the average sort of cost of caring for a person that leaves the hospital with a particular diagnosis. So they took an average over the 5-state area, and then that would be, with a 5% discount for themselves, what they would pay basically to take care of a person for the next 3 months. And the idea is, what you're doing at that point as the federal government is you're basically allowing the doctor or healthcare person, whatever it is, to compete with themselves actually to save money. So if you saved money and didn't spend too much money in the next 90 days, then you'd actually come out ahead a little bit.
Oh, yeah.
So there was an incentive to do that, to do a good job and not over-test people and all this kind of stuff. Yeah. Well, in North Texas, I think the culture of both of medicine, of medical professionals, and of patients is, if I have a problem, I'm going to access the ER. And I think that's I'll just tell you, having practiced in 5 other states, it's much more prevalent in North Texas than it is in other places. Well, as a result of this paradigm, we collected data, and we compared ourselves to other areas within that 5-state area. And if a person with a cardiac diagnosis shows up to the ER, in North Texas, they are 5 times more likely to be admitted to the hospital than anywhere else in that 5-state area. Not twice as often, 5 times. So,
that's crazy.
It is crazy. And again, I don't think that there's anything nefarious in that. I think it's actually just the culture of the healthcare climate, we'll say, in North Texas, is to access the emergency room as almost a first pass anytime you think that there's a problem.
Wow.
Well, for example, my office is available 24 hours a day, 7 days a week. I'm not answering the phone all that time, but somebody is.
Yeah.
And you are not more than 3 minutes away from talking to a cardiologist.
Wow.
A board certified, well-trained cardiologist. So if you go to the ER, you're not going to talk to a cardiologist in the middle of the night.
You're going to sit there and wait.
You're going to sit there and wait,
2-3
and you're going to
hours.
eventually talk to an ER doctor, and who has a lot of people to talk to. And they don't have access to your health records. Any of my partners has access to the entirety of their cardiology evaluation, all their tests, all those kind of things, what medicines have worked, so you're far better off, unless you're obviously in dire straits. If you can't get your next breath, or your chest feels like it's going to beat out of your chest, or if you're having chest pain or whatever, of course, the most appropriate thing is to go to the hospital. But very often, we're a phone call away, and very often even it can wait till the morning. So you can actually talk to your own healthcare provider.
And that means that if it's 5 times more than other states, that means those other 4 times are probably times that could be mitigated.
Very often could have been avoided. Absolutely. Oh, for sure. Yeah, I think many of the hospital admissions that happen in this particular healthcare community could be avoided. Yeah, I think it's very likely.
Wow. Man, as we're kind of wrapping up and coming to a close, what are some kind of final thoughts that you would kind of say just in general towards that specific issue when you're looking at patients, and you've seen so many patients over the years, and they're worried or they're concerned? What are some things that you could kind of give them some peace of mind?
Yeah, well, I think it depends. Some people need to be worried, because cardiac problems can be dangerous. But ask questions of your doctor. Know, number one, are you a person who is really in trouble, and if you are, what is the next step to mitigate that risk? And know what symptoms or signs or worries should bubble up to the level of I need help right now. Another thing that is an enormous problem in all of healthcare, particularly since medicines are often expensive, is compliance with medications.
Yeah.
So take your medicines. If your doctor has prescribed your medicines, there's a good reason for it. If they're not affordable for you, rather than just not taking them, inform your doctor that this is out of my price range. Can we work on something else? Yeah. And very often we can still get you that same drug, but we might need to access help.
Right. That's good.
I think for many people, they need help at home. So having somebody come, getting a relationship again with an entity like your company, having somebody come to your house periodically to have a look at you, measure your blood pressure properly, help make sure that you're getting your medicines properly. Also another point of contact if you feel like you're having trouble, to call somebody to, am I in trouble here? And your service will actually go see them, right?
100%. Yeah.
Go see them that day, and you can call me, and I love that when I get a phone call from a nurse who's in a patient's home, like, thank you so much, that is wonderful, because now we can partner on behalf of the patient to make their outcome better. And that is just wonderful.
Yeah, teamwork makes the dream work, they say.
It's wonderful.
Yeah.
So the other thing is we're always available. So, I know it's often when you call your doctor's office, they give you an appointment in 6 months. At least with my office, it's the next appointment you can come. You can come that day. So try to find somebody that you can access and get help from, and that kind of thing. But I honestly think communication with your doctor about the nature of your condition and what we're doing about it and what are the potential pitfalls, that's really important stuff.
That's good. That's awesome. We hope you enjoyed this first part of a 3-part series with Dr. Rick Ammar. You can find Dr. Rick Ammar at heartplace.com/provider and look up Richard Ammar. Stay tuned for the next episode. Don't forget to like and subscribe. See you next time.